Nice to see you again. Hello.
Hi.
Come and take a seat.
Okay, thank you.
Hello again.
Hello.
So you know Megan, our
Yes.
sister from Outpatients, and this is Dr. Fern, who I've
hello.
asked for her wise counsel, given your complex UTI
Yes,
problems
yes,
and the fact that we're not winning.
Yeah,
Um,
exactly.
So we thought we'd sort of have a joint effort to help you.
Thank you. Thank you.
So how are things now?
They're difficult because of the fact that I have got high epithelial cells. Basically, probably the best thing for me to do. Last time I came to an appointment, I gave you a printed out report from Focus Laboratories, and this time I printed out the second one I did.
Yeah.
If I take that, it'll probably be as easy as anything, isn't
That's
it?
good,
It's the
yeah.
same place.
Yeah, so the main concerns I have is it shows very high Gardnerella, enterococcus, and then as a secondary point, psilocybin or something. You know, sorry, what's the
Condoleezza.
Peptonophilus.
Peptonophilus, yeah.
And then when I looked at the ones that didn't quite meet the threshold below, some of them looked like, when I've researched all of these different bacteria, and some of them I am a bit worried about because they're kind of abnormal, you know. And yeah, so I'm just, and then yeah, that's what I'm worried about. Yeah.
So this is the
I
second
could go
sample
on,
from
but-
after we've. This is after you've seen me, or was
So
this?
yeah, so this is from. So the
This
last
is
time
it.
I saw you, I believe, was January. I brought in a private medical report from Focus Laboratories, which there's 3 companies Bladder Health UK work with: Focus Labs, Digital Microbiology, and then one in America. I haven't been to one in America yet,
Yes,
but I went to the
different
second one they recommended, which was Digital Microbiology, and I had this report done from a urine culture, which I sent off, and I got the results about a week later. And this is what I got sent back. So it's just the same thing I brought in last time, it's just a different company. But it's still recommended by Bladder Health UK, so it's still accredited, the company.
I mean, I will say I'm not sure they're accredited with the UK accreditation service. I don't know about this one, but the other one I looked up and I can't find any record of them on the laboratory accreditation service, nor on their website to say that they are accredited. So I think, which is often the case with private labs, and particularly when they're doing non-standard testing, because to be accredited you need to be following the, following or with evidence-based agreed, deviation from the standard microbiological investigation performers that are published by the Royal College of Pathology and overseen by the UKHSA. Lots of additional acronyms just to cause headaches. So I looked, obviously I don't know this one, but my guess would be that they're similar because a lot of the time they are. And the American one obviously definitely won't be accredited with the UK system because we don't accredit American laboratories from the UK. So I'm not sure how they're undertaking their cultures. I think the last one said it was a broth sample.
Yes.
And normally, I'll tell you why we normally use broth samples. We normally use a broth sample when we've got a sample from a part of the body that should be sterile.
Right.
So something like if you had a bone infection and someone took a sample from there, we would culture it normally on a plate and then we put a chunk of it in the broth, which is basically bacteria food. And the point of it is to see if it will pick up any sort of 1 or 2 bacteria, because it basically grows them for longer in bacteria food, so you start getting higher numbers. So you can't interpret the count from them in the same way as from a direct plate culture, which is more
Right,
wrong.
okay.
And the other factor is we always look at them with a little bit of a, they're not as reliable because you're picking them. So if you imagine you accidentally got a skin cell or a tiny, you're going to grow that bacteria, which you wouldn't on a plate because there's too little of it. But you'd be growing that tiny amount because you're basically going, come on, grow, and then I'll look. And in doing that, it means it's far more likely to pick up contaminants. And so it's always a little sort of, even when it's from a bone sample, if we had 5 bone samples and we grew it in 1 or 2 broth samples but no main samples, we wouldn't necessarily think it was a real result. So that's where the broths come in. The bladder isn't sterile, so inherently growing something from a broth sample from the bladder can't be interpreted in the same way as growing it from a plate from the bladder. So it makes it very difficult to interpret because they've put the numbers on it. This one hasn't, the other people have. They've reported it in the way that you'd replate the standard sampling, but you can't compare it because of the way they've cultured it. I'm looking at this and that all looks like normal vaginal flora or just vaginal organisms rather than vulval organisms. All of these are anaerobes that are, well, the streptococcus is probably a pretend anaerobe, but they're all anaerobes. We get them. This is one of the joys if we have machines that now name everything because of the way we test it. If you go back 10 years, these would have just been called anaerobe.
Oh, I see, okay.
Now we name things, it causes headaches. So I wonder whether there might have been some vaginal flora contamination. That's the first thing I think when I see that list of bugs. Gardnerella vaginalis is like, I mean, it tells you its second name. It's found in the vagina. We're not very imaginative when we name bugs a lot of the time. You can normally work something out about that. So that's my instinctive feeling with that, is that there's probably some pickup. I can't say for sure, obviously, but that's what it looks like to me. Which doesn't help with the fact that you've been having the symptoms, but I suspect. I'm sorry, I'm reading there.
So whilst you're doing that,
I'll digest the key information.
Can I just ask, could you just remind me of what your symptoms are at present? What happens? So I've given you some medication, I've given you some ciprofloxacin, and then I've asked you to go on something called methenamine hypurate. Hiprex. Are you on that at the moment?
I am taking it, although I must say it's in combination with the ascorbic acid. I think because of the fact that I have high indication of a bladder infection, I think it's kind of, because it's acidic, it's slightly irritating.
And how do you perceive that? How do you know that it's irritating the bladder?
Because of the urge incontinence, and because of the pain, and the feeling of inflammation in my abdominal area.
Okay. But are you taking the Hiprex? Because on the GP tab it appears that it's not there. Or do you still have something left from when I prescribed in February?
You prescribed me a good amount.
I did, so you still have something left. Okay.
Yeah, I have.
So at the moment you're on Hiprex, but you're omitting the vitamin C because you find it irritant.
Yeah, I did find it. I had a very, very bad day where I was kind of like, this feels intolerable. It also quite negatively affected my energy levels. I wasn't really able to, I'm not really sleeping at all really because of the fact that
You attribute that to vitamin C, you think?
No, like I said, I don't know if it is the vitamin C or the Hyprex, but I know that Hyprex is acidic, so it could potentially...
Vitamin C is more acidic.
Oh, it's acidic. Well, whichever one's acidic, because my urine's already acidic because I have a bladder infection. That's why you take
it's normal to have acidic urine.
to make it less acidic.
It's normal to have it's to do with making the urine a hostile environment for bacteria if you do have bacteria in the urine.
Like a disinfectant kind of thing.
Sort of, yes. Now, the ciprofloxacin you think has not made any difference to your symptoms?
I must say in terms of an improvement of my symptoms, I think the only 2 antibiotics that I've noticed have ever really made a difference is the combination of coamoxiclav and trimethoprim, and then that seemed to help. And then once I had clarithromycin, and that helped because I was having like a stabbing pain in my abdomen, and that was prescribed at St James's same-day GP service. As for the ciprofloxacin, it was a horrible couple of weeks. I felt very, very, very dark. I was very ruptured my knee. I was very worried my knee, which is already ruptured, is going to kind of get blasted. And it was just a very difficult couple of weeks, and I can't say honestly that it really did make a marked difference in my symptoms.
You had that for 2 weeks?
Yeah, I had that for 2 weeks.
So if I take you back to actually what your symptoms are, could you just describe in your own words, what do you feel? What would you attribute to a UTI? What are your symptoms today, or what were your symptoms yesterday?
Pain on urination, so burning.
Yeah.
Can I just ask, do you think that's in your bladder or in your urethra as it's coming out?
Urethra coming out, I think. And then the main problems is the urge incontinence, so needing to use the bathroom very frequently.
Urgency.
And
how often do you go to the toilet?
Overnight, it's at least 7 times before I can even think about trying to relax enough to be able to sleep, because I just know that in 2 minutes my bladder will be full again.
Okay. So, all right, fine. So once you are asleep, how often do you wake up in order to pass urine?
I don't wake up, but the main issue I should realise I'm getting on average, if I'm lucky, and I can't stress this enough, if I'm lucky I get 5 hours sleep, because of the fact that my bladder will be emptied with the residual volume by the time I've been 6 times. Then I'll fall asleep, and my body will enable me to sleep for 5 hours before my bladder's full again, which wakes me up, and then I don't get back to sleep.
But you're not going back to sleep?
Yeah.
Okay, so there's a lot of information in there. So you go to. So why do you say you empty your bladder with a residual volume? Is that because you feel you're not emptying properly?
So I'm not, because I think the issue here is that because it's not, for example, my epithelial cells are not 1,000, they're 15, so that's not an acute pyelonephritis. And in terms of the residual volume that's left in my bladder, when I went to the Avenue private clinic in January to do the ultrasound scan, there was a residual volume of 16 millilitres.
16?
16 millilitres, but that's not 1/6, but that's not 1,500, so it doesn't indicate pyelonephritis. But I think when you combine the fact that all of these slight abnormalities, if you put them all together, it does indicate that there's something wrong. It's just in isolation, they don't indicate severe acute, kidney infection.
Well, I don't think you have a kidney infection. I don't think epithelial cells with possible residual of 16 will in any way suggest you have a kidney infection.
Right. Pyuria, though, I have pyuria.
I'll go to the epithelial cells. The epithelial cells are skin cells, so those are picked up normally from the urethra, the vagina, and the way out, so they're not coming from higher up.
Right.
Those are. So normally, again, if we look at a sample that's got a lot of epithelial cells in it, it gives us a suggestion that it's not necessarily been a fully midstream urine, because it's picking up that shedding of cells that's quite normal from urethra and vagina. Right. So that's more likely what's coming through the epithelial cells. That's not coming from higher up.
Because I thought that if there were a lot of epithelial cells, that's a sign that my body is shedding, it's fighting an infection, it's shedding a lot.
It's things like, if I rub my skin like that, there will be epithelial cells. I will be donating them. She says, I won't keep doing that in case nobody wants my donated.
And a phosphoid residual of 16 is non-significant. It's not significant.
Yeah, in isolation it isn't, but I think when you combine them
in any circumstance, a phosphoid residual of 16 is insignificant and not clinically relevant in any circumstance.
Okay.
Even in a child.
Okay, that's fine.
Yeah. So
less than my son had on his scan.
Yeah.
Well, everything you're telling me is that there's nothing wrong, but I'm here now in hospital, I've cycled all the way here, this is my second appointment, You're just telling me there's nothing wrong.
Well, that's why you're here.
Why am I here?
You're here to get answers, and you're here to sort of try to get on top of your symptoms.
Yeah.
So I think we probably are really focused on UTIs. But I think what you're describing in terms of your symptoms is perhaps more type of an overactive type of bladder with your urgency, your urgent incontinence, your frequency, which has not been addressed in any type of medication or otherwise. So I think...
Sorry, I just have to interject here because
Please.
I kind of feel like... I'll be honest, I'm quite concerned because what you're holding in your hand right now is a document, and I have to completely disagree because this is an accredited company. Dr. Sarah Montague from the very, very, very well-known women's health company DAYE. I had a private consultation with her, and she referred me to Bladder Health UK.
Yeah.
Bladder Health UK is an accredited organisation. They have a charity number, they're accredited. They work with, can I please finish what I'm saying with all due respect? I haven't finished what I'm saying. I've let you speak for 15 minutes at the beginning of this appointment. I would now like to speak because I'm the patient, I'm the one suffering here. So you're holding in your hand, I've spent £250 on that report. I've spent another £150 in January. I spent another £110 last November on these reports. That's over £650 on private medical reports, which are all accredited. So just because they're not standard NHS testing, they're private healthcare.
Yes.
And I may not look like somebody who... No, let me finish. No, please let me finish.
Lydia.
I may not look like somebody who is maybe justifiably going after private healthcare, but this is private healthcare. This is accredited private healthcare. You're holding a report in your hands now, which says that and this is very concerning, because
Okay,
you're
Lydia,
another woman.
we just need to tone it down a minute.
You're
okay?
another woman.
Lydia, we need to tone it down, okay? I'm not saying you can't finish what you're saying, but there's a way in how to say it. We just need to tone it down a little bit, okay?
You're a woman.
I am.
Yes, you are.
Yes.
You're a woman. You're a woman. And that report says that I have over 180,000 colony-forming units of Gardnerella vaginalis.
Yes.
Now this gentleman here, he may not know what that means. You're a woman, and you're a woman, and you know exactly what that means. So don't you dare look at me and tell me that is normal, because you know full well that having above 180,000 colony-forming units of Gardnerella vaginalis is not normal. A, because it signals bacterial vaginosis, which can lead to infertility if left untreated, and B, because usually you don't get Gardnerella vaginalis in the urinary tract. Usually it is isolated in the vaginal cavity, in the birth cavity. So do not sit here in front of me when I've taken a day off work and had to put my 3-year-old son in childcare and have been in distress for over a year with this infection. And you have a report there which I've spent over £250 on, when I'm a mother of one on benefits, on long-term sick leave, on personal independence payment, who spent over £250 on this report. And you seriously have the audacity to look me in the eye as another woman, probably as a mother of 4, and tell me that that level of Gardnerella vaginalis is normal. It's not. It's not normal. And if you, with all due respect, gentlemen, sir, whoever you are, if you are seriously telling me that that is not evidence of a serious infection, I don't know what to tell you.
Well, what I can tell you is that we're here to help. Okay, you might not want to accept the advice we're giving you, and that's fine. That's entirely your remit. We're here to give you the advice that we have been educated to give. Okay, I don't think you've got a serious infection. That's it. That's my
But what
opinion.
about the Gardnerella vaginalis?
Well, I
Which is quite a lot of
suspect.
pressure.
No, I agree with that. But well, let's take one at a time. So I think that you are suffering with some lower urinary tract dysfunction. I agree with that because you've got symptoms. You've got storage type of symptoms. And you have a culture that shows possibly contamination.
Potentially.
Yes.
Potentially that is the case.
Yes.
But with all due respect, if I'm literally having washed my hands and I'm holding a urine sample midstream and then I'm giving it to a doctor or I'm putting it in the post and I'm not walking across Leeds with it, brandishing it about, or giving it to some friends to give their samples, I'm just doing the sample and putting it in the tub and giving it to you. And I hear what you're saying about the contamination, but I'm trying to work out why is this? How could it possibly be contaminated when I'm doing the sample and handing it in and that's all I'm doing? Because I've now just had to change GPs because of this problem where I'm being told over and over again that it's contaminated. But surely the contamination is indicative of the fact that there we have 9 different microorganisms. And yes, I understand what you said at the beginning, several of them are normal, but on the report, which you cannot see there, on the report online, it says that about 4 of those 9 contaminants are pathogens. Yes. And that is the key word. And then about 3 of the 9 are maybe pathogens. And if I didn't want to take up more of your time, I'd log in, I'd show you the one where it said pathogenic, potentially pathogenic, don't have enough information to prove whether it's pathogenic, because it doesn't say it on that report. But there are about 4 of those microorganisms.
Yes, it's got the stars and
pathogenic, I looked this up yesterday because I've spent hours researching these reports. Pathogenic means shouldn't be there, could be causing an infection, potentially dangerous. So this is what I don't understand, is if I have pathogenic bacteria in my urinary tract, that is a sign that there's something wrong. And obviously then you'd have to do the culture and check, is this colonising pathogenic material, or is this non-colonising? Is it just dormant? Which is again why I potentially do slightly understand what you're saying. But I'm at my wit's end of this. I've been suffering with this for over a year, and like I say, I think I need a CT scan. I think a CT scan
Why
will
do
show
you think you need a CT scan? Why do you think you need a CT scan?
Because a CT scan would be able to show you the function of my kidneys, my ureters, my urethra, and my bladder, and it would also show up anything such as inflammation or infection. A CT scan is a lot more detailed than an ultrasound scan. An ultrasound scan usually just shows up tumour. An ultrasound scan will not really give you any sign of infection, and that's what I think I have. I think I have an infection. I think I've had this infection for a very long time, and I think that a CT scan would give you a lot more answers than the ultrasound that I had.
So I don't think the CT scan would be helpful in this situation. The CT scan will just show you the structure of what you just described, the kidneys, the ureters, the bladder. It won't tell you if there's inflammation, and it won't tell you if there is, it won't tell you how your system is functioning. It just gives you a picture. I don't think the CT scan is warranted here. I wouldn't request a CT scan. I don't think there's any indication for you to have a CT scan. There's nothing that we will gain by doing a CT scan. It's literally
just please can you answer this?
Of course.
What about the Enterococcus? Because that is not a normal bacteria to be in the urinary tract. And Enterococcus often is linked with a UTI. So, for example, I emailed Nick Parkinson, who's one of the doctors who wrote this report. I actually got an email, which I could show you now, but like I said, I don't want to take up more of your time. I could show you the email, but he has said to me in this email that he believes, I said to him, with the peptinophilus. I'm very concerned about the peptinophilus because I've looked it up online. He said, don't worry about that for now, focus on the Enterococcus. Make sure the Enterococcus is cleared because that's the one that's linked to the UTI.
So I was going to say, of all of the organisms on here, the ones that are most likely, and not universally likely, but not guaranteed to cause a UTI, but most likely is the Enterococcus. Yeah. The Gardnerella is BV. That's what it's linked with in the vagina, and you're right, it is a lot of them. It's not known to cause UTIs, which is, so I wasn't disregarding it entirely, it's more I was looking at those ones largely. Those are all anaerobes, they're very vaginal flora. So the Gardnerella, and I think you've also had some metronidazole, which is what we would use to treat the Gardnerella. I can't say that one very well, Gardnerella. Yeah. It's got too many vowels in the middle of it.
Can I just ask, why do I have vaginal flora in my urinary tract?
It's quite common in the lower ureter because they're not far apart. So the exit of your urethra is very close to the exit of your vagina, and so it's all sort of fairly homogeneous, essentially. We call it perineal flora. So the anaerobes, you will get more of them in the vagina than on the outside because there's less air, essentially. But the bottom part of your urethra, I can't speak today, urethra, is often colonised with the bacteria from around. They basically creep up the end of it. And so that will include vaginal flora, and it will include perineal flora. Most commonly, Enterococcus it can cause UTIs. Most commonly it causes UTIs in people who have something else going on in their urinary tract. So they've got a stent in situ, or they've got stones, they've got, even though it's normally things like stents, or somebody's got a catheter in situ. So it can cause, and this is where I think it talks about pathogen. Like a pathogen is capable of causing an infection and may be quite likely to. An opportunistic pathogen is one that does it in the right circumstances. Enterococcus is a pathogen, but it's not, for want of a better phrase, the best of pathogens, and by that I mean it's not the best at its job of being a pathogen. So if you were immunocompromised, if you had cancer, anything like that, then that will increase your likelihood of it being able to cause an infection. But it is a bug that lives in your GI tract and lives in your perineum. So most commonly when we pick it up on urine samples, it's been picked up from the end of the urethra. Now, having looked into the other things, and again when I talk about accreditation, I'm purely talking about the microbiological lab accreditation. I don't know about anything else. But having looked at the other one, I'm aware that they give you very clear instructions on taking an MSU, which, given everything you've been through, I am assuming you have gone through, that you are taking a midstream urine. It's not the first bit, you're weeing a bit and then catching the middle section.
Well, I mean, when I was trying to do this sample, it was very difficult to get the sample because, I mean, sometimes I'm barely able to urinate. It's just a dribble, and
so is that potentially what this sample, I mean, I'm not saying that is it, but if it was a very small amount of urine and you weren't able to wee for a bit and then catch the middle bit, you might be more likely to be picking up the bugs from urethra, let's say the right words.
Potentially, I don't know, sometimes I'm thinking to myself, I mean, when I saw a nurse last year who wrote a letter, which again I could find to show you, but I won't. Basically, she did a speculum examination and said that she saw signs of pyuria, which I've looked up is pus, on my cervix. That's what's in the letter. So the reason I'm concerned is because there's indications here of pyuria pus in my urine as well. So
pyuria is in, I think.
Yeah, that's right.
You're muddling up the words pyuria, which is understandable because there's a lot of them. Pyuria is specifically pus in the urine.
Not necessarily pus, just white cell. Just white cell in the urine.
Yes.
White cell.
In terms of the white cells, beginning of 2024, I was at the Marion Centre, was told I had white cells. Then I checked online, leukocytes, last April.
On dipstick tests.
In urine, vaginal swabs. Then I was told last April, or the April before, I looked on the NHS app and it said leukocytes 14.
Yeah.
And then I know that my white cells aren't as high. They're only about 4. Yeah. But they are still. Yes. In the urine, they are about 4, which isn't majorly concerning, but it could indicate some kind of.
So I will address the white cells. So I've looked at all of your urine samples that have been tested in our lab, obviously, because I can't see all the other ones. So when we test for urines, the cut-off, so they obviously stands in microscopy, it counts the numbers of cells. The cut-off to suggest that there are white cells to the extent that they could be suggesting there is enough inflammation to suggest an infection, the cut-off is 40. That's the one that the machine uses. So if you've got fewer than 40, that's considered within the normal range of somebody without significant inflammation in their bladder. So when we've cultured your urines, we culture based on 2 main things in microscopy. One is the number of white cells seen, and one is the number of bacteria seen. And all of your cultures have either not been cultured because they didn't trigger either of those, and so you don't go on to putting them on the plate if you don't trigger on either bacteria numbers or white cell numbers. So they either aren't cultured or they've come back, they've triggered because of the bacteria numbers, which isn't an indication of where the bacteria have come from, just that there's enough of them in the sample to trigger, which is when you've then got the mixed growths or the no significant growth. Yeah. No significant growth normally means it's a mixture of sort of skin fold type organisms that aren't causes of UTIs, or they're really tiny amounts of them. Mixed growth means there's decent numbers of, often again, skin fold organisms and
mixed growth. This is a term I was told I had when I was 8 months pregnant. So I really, really want to get to the bottom of what it actually is. From my understanding my basic reading, and please correct me if I'm wrong, I'm under the impression that mixed growth essentially is just, you don't have one growth, you have 4, or you have 8, or you have 15. So you don't just have Klebsiella, you have Klebsiella, Pseudomonas, Enterococcus, and whatever's on that report. Am I wrong? Is that not what mixed growth is?
Mixed growth will be used invariably. Yes, you're right. It means there is more than one organism, but how it gets used. So if you had a Klebsiella and an E. coli, and there was a good amount of both of them, and it was equal, they would both be reported. They'd be named and reported. So mixed growth is what's used when there's, 2 or more, and there's no predominant pathogen essentially.
Right.
So it could be 3, it could be 2, it could be 3, but there's no heavier growth of one specific or 2 equally heavily growing or significantly growing known pathogens, which are normally the gram-negatives. So it could be that there's 3 and you've got skin flora and bits and pieces in that. It comes back as mixed. It's purely a description of that they have different colonies on the plate, but there's nothing predominant to suggest that one of them is the cause.
It just would appear from this report that
the
Enterococcus is above the threshold, and then in the report I had from January, it did suggest, and again, it begins with an A, it's a group of antibiotics that include gentamicin, amikacin, and
it's tobramycin,
and they can either be administered through an IV drip or through an intramuscular injection. So this is why I'm concerned, because I know that the Pseudomonas from the report in January is indicative, but then like Nick Parkinson has said, you need to focus on the Enterococcus and you need to get that treated because that's the one that most likely would be causing the symptoms of a UTI. So like I say, it's not like one doctor's wrong, another doctor's right, one doctor's wrong. It's just that's why people ask for medical second opinions, because different professionals have different experiences and specialisms. But from my perspective, this is my son here on his t-shirt, and I've majorly let him down. I've let him down because of this infection, which has been going on for so long, and it's made me feel like an absolute failure because
I don't
can't
think that
sleep.
is the
So
case.
how can I look after a 3.5-year-old if I can't sleep? And I don't know if it is these pathogens which are in my body. I haven't paid for any of the vaginal microbiome. You can get those at this lab. I haven't paid. That's another £200. I haven't done that. Am I going to have pathogens there as well? I feel like very much like I have a lot of pathogens, and that concerns me.
Can I just say something a bit?
About this boy. I don't want to be pathogenic around a child like this.
But he will have his own bugs on him. You will have your own bugs. I will have my own bugs. We all are covered. You need them. That's what keeps us healthy. Yeah. So they are called commensal pathogens. They live with us and they form part of your flora.
Non-pathogenic.
Well, not necessarily.
But ones I have are pathogenic.
Not necessarily. It's when they get to the wrong place and when they're invasive and cause inflammation that they're a problem. So on my skin at the moment, I might have Staph aureus. If that got into my bloodstream, I would be horrifically sick. But it's fine on my skin because actually it's okay there. It's still a pathogen, but it's not causing an infection at the moment. In the same way, Enterococcus, E. coli, they are in your gut, and they're meant to be in your gut. And
so why are they in my urinary tract?
Well, as I said, they're often around the exit tube because of the nature of the union. All of your exits are in the same location, so they're really common in the perineum. If they're not invading the tissue, and if they're not causing inflammation locally, whilst they are pathogens, being called a pathogen means you have the capacity as a bug to invade and cause an infection.
Doesn't mean you are.
Doesn't mean you are.
Doesn't mean you are. You just have the potential.
Which I think, and I understand you hear the word pathogen, it sounds alarming.
Problematic, yeah.
And depending on where you find them, depends on whether you're, if we found Enterococcus in your blood, we'd be certain it's not meant to be there. But Enterococcus in a urine sample is a bit more hazy. And so it's not, so you do have pathogens, that's not incorrect, but if they're not causing invasion and tissue invasion and inflammation, they're not at that point behaving in a pathogenic way. So I think I'd just be wary of the word pathogen because it doesn't necessarily mean it is causing an infection at that time. And so I'm talking very specifically about the nature of the bugs here rather than the implication. I was going to say something else, and it's gone out my mind currently. I think you said you had the metronidazole, and I think you've had.
Well, yeah.
I
mean, I was given this prescription for clindamycin for the
that
DV.
will be for the metro.
Oh, you've seen.
But I haven't collected it because I wanted to check with you first, and I didn't get it from yourself.
So you've seen Matthew Malone Lee as well.
Well, I've been very desperate. You know, I had to call the paramedic twice last year. You know,
So
I've been in tears.
He's running
had
a
a
private
crying room.
clinic.
I've been in tears most days.
I
over
know.
this.
His father set up one of the clinics in on Harley Street. He's died, I think, 2 or 3 days ago.
Okay.
Yeah.
Yeah, I mean, you know, like I say, it's different medical opinions, but
And
you
you
know,
were.
he prescribed me this,
Exactly.
and I wanted to run it by you first. You know, because I thought that it would be very beneficial to run it by you first.
Do you have any benefit after the metronidazole? You've had some metronidazole, haven't you? Other than it possibly making you feel slightly
So
sick.
he's prescribed me coamoxiclav with trimethoprim as a combination.
Now, as well as this.
Yeah, so I've been on that since
Malone
last
Lee.
Wednesday. Yeah, I didn't have time to these are random
Okay.
letters. I didn't have time to bring in the other prescriptions, but they essentially are, and this is what I wanted to ask you. So for the last, this is me hand on my heart being honest here. For the last week, I've been on coamoxiclav and I've been on trimethoprim as a combination. It has markedly improved my symptoms.
Oh, and that's the
But
reason.
whether I continue it,
Okay.
that sort of remains to be known from yourselves.
And what dose of those are you on? Do you know? Is it 625 milligrams?
I can tell you, I took a picture on my phone of the dosage so I can tell you.
Probably is. I'm trying to just